In metastatic patients in the US, in most of the European countries, immunotherapy has dramatically changed the second-line treatment. We were used to deliver docetaxel since 2000, where it was shown to be better than nothing, right? But docetaxel is difficult to deliver, lots of toxicities, very poor tolerability, patients hate it. So it was something we were doing because of guidelines, but not really because we were improving the fate, or we were just prolonging survival, but the conditions were not very good. So since 4 randomized trials showing immunotherapy, whichever compound you use, is better than docetaxel, we were all very happy to adopt immunotherapy in that setting, regardless of PD-L1. Docetaxel is such a bad treatment that whatever the category, PD-L1 low or PD-L1 high, you would be better than docetaxel. Of course, the magnitude is different. If PD-L1 is low, you have a small difference. If PD-L1 is high, you have a big difference. But it's better than docetaxel. Dramatic change. Most of the European countries have some access to immunotherapy in second line, one drug or the other one. The next advance was to move it frontline. And again, by selecting patients for being potential responders, and this was based on PD-L1 expression, taking the very high PD-L1 expression, more than 50% of the tumor cells expressing PD-L1, pembrolizumab was shown to be better than chemotherapy. But it's not docetaxel, it's platinum-based chemotherapy, which is a good chemotherapy. So in this scenario, you can use pembrolizumab. It granted approval in Europe in December last year, and countries are time after time starting to reimburse it in frontline in high PD-L1. So second line for all, and frontline in selected number of patients, maybe 20 to 30% of them. And of course, every country has its own regulation and reimbursement processes. And unfortunately, in Europe, we are now in an imbalanced environment where the chances to get access to this kind of drug is not the same in every country. We have to work on it.
All patients must be tested for PD-L1, because if you have a proportion score of PD-L1 more than 50%, you are allowed to treat patients with pembrolizumab. And we know that the results of the KEYNOTE-024, which compared pembrolizumab to chemotherapy, showed also with a long follow-up very good results for this kind of patients. And the prognosis of patients with advanced non-small cell lung cancer treated with pembrolizumab and with a proportion score more than 50% is about 30 months. Which is very different from what we had before. I'm not sure that I will give you the same answer in the next future, because the scenario of the treatment of advanced non-small cell lung cancer in 2018 is challenging, because we will have to see very carefully at least 2 trials, which are the BMS 227, comparing the monotherapy and the chemotherapy plus the anti-CTL4 in the metastatic setting. And the other very important trial is the KEYNOTE-189, comparing the use of chemotherapy with chemotherapy plus pembrolizumab again. So we will have to see very carefully if in the subgroup analysis they will be independent or not by the expression of the PD-L1, because there is a strong rationale to combine both the anti-CTL4 and also chemotherapy. So it will be quite challenging to tailor the treatment for this kind of patients. So the story is that all the tests are not interchangeable. It is a quite interesting story, because all the companies develop the drugs with their own tests, and so we have the drug with the test of the company, and there are several trials trying to harmonize all the tests. What it seems clear is that one test, which is the SP142, which is the Ventana test, seems to be different from the others. And another important piece of information comes from the harmonization test of the French group, which says that if you do a laboratory-derived test in your own, maybe you are not so reproducible as the label test. So in my opinion, it's better to use the commercial tests that are proven to be the same. And for example, one is that one of pembrolizumab, which is the 22C test. Yes, the last part is that don't do in-house tests because they can be not reproducible. And it is better to use commercial tests with the exception of the Ventana SP142 assay, which can be quite different from the others.